Hello, very good evening to one and all. Welcome to the first ever She Unites webinar series by ASAMI India. I'm the convener, Dr. Ishani Chaudhary, and today we have very prominent faculty and panelists from ASAMI India. I would like to welcome the president, Dr. Rajat Agrawal, sir, the Secretary, Dr. Shamsul Hoda, sir, the Treasurer, Dr. Ravi Chauhan, sir, Dr. Manish Dhawan, who's the past president, our moderator and past president, Dr. Ruta Kulkarni, ma'am. And I would also like to welcome Dr. Vasudevan, sir. We have the strong support of OrthoTV and Asami TV for this wonderful series. And I would like to thank our esteemed panelists for giving a good, enthusiastic support for this series, which consists of case based learning. And I would now like to hand it over to Dr. Ruta Kulkarni, ma'am, who would be introducing our speakers for this first ever webinar series.
Yeah. So good evening, everyone. I am truly proud to welcome you all for this unique webinar, She Unites. It's inspiring to see these accomplished women in this challenging field of Elizaro limb reconstruction and deformity correction. I'm thrilled to introduce these four dynamic ladies, Dr. Aradhana, Dr. Ishani, Dr. Godhasiri, and Dr. Madhura. Each of them is doing wonderful work in this field. So I think Dr. Godha will go first. So I'll introduce Dr. Godha in short. She has done MS Orthopaedics from Osmania. She is a consultant orthopedic surgeon right now working in Phoenix Limb Reconstruction Clinic in Hyderabad. She has done fellowships in limb reconstruction and in lengthening in Bangalore and Palakkad. She has also done fellowship in pediatric orthopedics from Ahmedabad. She has 3 and 6 international publications. She won Best Paper in BOSCON 2019, and she is the winner of Dr. Junjunwala Gold Medal Paper session in ASAMICon 24. So, Godha, I invite you to do your presentation. Dr. Godha.
Thank you so much, ma'am. I'll share my screen.
Yeah.
Is my screen visible?
Yes, go ahead.
Yeah. I thank ASAMI India for giving me this opportunity. And I thank all the panelists and our moderator today, Dr. Ruta Kulkarni, ma'am, and the convener, Ishani, for giving me this opportunity. So I'm going to present 3 interesting cases today. And the first one is a double trouble case. So I had a 23-year-old female patient who presented with multiple discharging sinuses from the lateral aspect of the left thigh. She had profuse purulent discharge and an adherent scar over the anterolateral aspect of the thigh. To add to the trouble, she also had this, she came with this wrist with a sequestrated distal and radius projecting out of the skin. Her history revealed that she underwent interlocking nail femur an year ago, and since then she was bedridden. She had discharge from the site after 1 month of nailing. And then she said that her distal and radius fracture, which was initially a grade 3 compound, was treated conservatively. So this is how she presented. And these are her radiographs, the radiograph of the femur and the radius. And we can see that there's a sequestrated bone segment with an SS wire around it, and the sequestrated distal and radius as well. So the questions in my mind then were, what is the best treatment plan for this patient? As an Elizaro surgeon, I knew that Elizaro would be a better option because it can eradicate infection, number one, and then it can give reliable union, and there will be no limb length discrepancy as well. But the next question was, will she be able to tolerate the fixator in both the lower limb and upper limb simultaneously? With this question, I just took up the femur case first, removed the nail, debrided, removed the sequestrum of bone which was present. And then again, the next question was, should I pass an antibiotic nail first, wait for the infection to subside, and then put the frame on? Or should I just put the frame on first? The patient was bedridden for a year, and the thing that she wanted the most was to walk. So I thought it is better to put the fixator on, gain her confidence. She'll be able to gain confidence of the fixator, and she will allow me to proceed for the forearm frame as well. So I placed an antibiotic spacer and put a frame. And these are her clinical pictures with the frame on. And then the following week, she was quite comfortable, and hence she was okay for the forearm frame as well. The following week, I proceeded for the forearm fixation. And the plan was, the bone was very, very thin. So it was difficult to for a single bone forearm. This transporting the radius from proximal to distal and then fusing it to the wrist, I felt was a better option for her thin bone circumference. So these are the clinical pictures. And the plan was R1 was a constant ring to the metacarpals. R4 was connected to the ulna and radius as well. R2 was only to the ulna and fusion to the wrist. And R3 was the actual transport ring. And the red line denotes the corticotomy that was planned. The plan worked well. And this is her sequential radiograph. The yellow arrow denotes the corticotomy site and the transport in progress. And she was quite comfortable with the forearm fixator also. She was able to do most of limited day-to-day activities like fine movements of the fingers she was able to do. And after 4 weeks, once the sinuses healed and once the wound sites were closed, I went ahead and did a distal femur corticotomy and proceeded for transport for the femur. There were no issues. It went well. There was some medial deflection of the transport segment, which I corrected with differential transport. Meanwhile, the forearm went ahead and the transport went ahead quite well. And once the transport was completed, I docked, bone grafted, and fused the wrist. And this is how she managed with both the forearm and the femur fixator in situ. Looks quite cumbersome, but she was quite comfortable with it. She was walking with a cane support only. And then, once the transport of the femur was done, I did docking and bone grafting. And then it went on to unite well. The regenerate also consolidated well, as we can see. I removed the forearm fixator first at about 8 months. And this is how she has pretty good functional range of movement. And at about 14 months, I removed her femur fixator. And this is her gait initially. And I gave a splint for the forearm also. And these are her latest follow-up radiographs. We can see that there is good union at the docking side, good consolidation of the regenerate. The forearm is also doing quite well. And these are her functional abilities. She does have some limp because of the stiff knee. She does have a stiff knee and she does require a quadriceps plasty later on. The second case is of a 24-year-old male patient who presented like this, who operated elsewhere, and he underwent a distal femur locking plate 8 months ago. And then after that, he had profuse discharge from the operative site since POD 5. So this is how he presented. When I saw the radiograph and the clinical condition, I thought I could get away by just removing the plate, removing some sequestrum, and then applying a fixator. Little did I know that there would be a big sequestrum, a free fragment with profuse discharge with 16 centimeter of bone loss. And again, I was juggling between what to do intraoperatively, whether to place a nail or place a fixator first. And this would be my first proximal femur transport. So a lot of questions in my mind. But then I went ahead, placed a fixator, but placed a bone cement antibiotic spacer. And after 6 weeks, the wounds closed, the discharge was quite less, but there was some amount of serious discharge from the operative side. But I still took the risk and did extended the ring to the proximal femur and did a proximal femur corticotomy and proceeded for transport. The sequential series of radiographs showing transport in progress. And when it was ready for docking, I took up the case for docking. But then what happened was, once I opened the operative site, there was a lot of bleeding. The distal femur was extremely fragile. The patella was literally paper thin. And I knew that I couldn't salvage the knee. The only option left was arthrodesis. And all I did was placed graft all over, used patella also as a graft all around, and prayed for a arthrodesis. And it went on to unite well. Good signs of union we can see over here. The regenerate also about 16 centimeter consolidated really well. And the patient, this is the video showing the patient walking with the fixator on, a very cooperative patient. The frame was removed at about 18 months. Yes, I did take a lot of time for this case. And these are the radiographs post removal. I gave a slab support for a few weeks. And these are the follow-up radiographs. His gait is pretty well and he's doing pretty well. Does have a stiff knee, but then he's able to do most of the activities, if not all. The last case is of a 27-year-old male patient who also presented with multiple discharging sinuses. He underwent 5 surgeries, and which included multiple interlocking nail femurs, and which also included an antibiotic nail. And this is the spacer that was there. This was when he presented to me with a spacer on. And yes, there were multiple options for this. I could have just removed the spacer, exchange nailing, bone grafting, but then I always rely on Elizara and went ahead and did put on the frame. I didn't do a corticotomy then in the same sitting because there was some amount of discharge and I didn't want to take any risk because this was his last resort after multiple surgeries. And after 4 weeks, when the sinuses closed, the infection was quiescent, I went ahead and did a distal femur corticotomy and proceeded for transport. At the time of transport, there was some deflection of the segment, but the overall alignment was maintained. So I just took up for docking, docked, bone grafted, and then there was some limb length discrepancy. So I continued the distraction. And these are the follow-up radiographs. This was when I removed the fixator on. This is how he used to walk in the final stages of treatment without any cane, without any support. And these radiographs are the follow-up radiographs after the fixator was removed. This is the latest follow-up. He just underwent Judeth's quadriceps plasty on Saturday and has about 70 degrees of movement at the knee joint. That was how much I was able to gain for him. And a special mention about the stiff knee. The cases presented over here, all the 3 cases had stiff knee preoperatively. Hence, I couldn't do much for it. But if a patient presents to me early, I always make sure that he has good range of knee movement and the fixator does not cause any issues in decreasing his knee range of movement. I hope the cases have given some academic points. Thank you.
You can stop sharing the screen. Good, very good cases. Excellent cases.
Ma'am, thank you, ma'am.
Cases are open for discussion. Anybody has any questions? Yeah. Yes, Dr. Dhawan.
Am I audible? Okay.
Yes, sir. Yes, sir.
I have to really congratulate you. Very nice cases.
Thank you, sir.
It is not actually just few comments,
Yes, sir.
Your first case. See, I have burned my finger, not specific to your case, but in my practice, I have burned my fingers. Don't try to avoid putting any of these thin wires to the medullary canal. First thing. In your case, the ends were very, protruding very less, so it is okay. But I have burnt finger in the sense that what people do, they make a antibiotic not over the wire and they put it in the canal and not using the K nail. I had 2 patients. I had to split the tibia whole length. I think the
Actually, I didn't pass it all through the nail, sir. I used it only as a spacer, only at that space, not all along the length, so that I can just remove it off.
I think.
It's working, sir.
Dr. Dhawan, you are audible and visible. You can talk.
Yeah, Gola, what is the advantage of keeping a cement spacer?
Yes, sir. There was no advantage. I know I could have waited and just proceeded for corticotomy, but then there was a lot of infection in the medullary canal, and I thought maybe the antibiotic delivery at the local site would help me with the corticotomy
That's
later
right.
on.
But why infection?
Because of the nail in situ and the sequestrum, which was already removed.
So that you removed means why the infection is good? Because you see that is the rule of the nature.
Yes, sir.
When there is a debris there, either the surgeon has to remove it. If you don't remove in right time, the nature will call bacteria there and pull it out.
Yes, sir.
They are doing the job. Actually, no, I don't even rely upon antibiotic much.
Yes, sir.
You done that much out, you don't need that much antibiotic. You need bacteria there to take it out.
Yes, sir. Right, sir.
And because I think the waste of money, and again, as Manish mentioned, no, removal of it again, another job for you.
Right, sir. I do agree with this, sir. But in the later
And-
cases, I haven't used any antibiotic
And
system.
all the cases, no, and all the cases are really challenging cases.
Thank you, sir.
Yeah.
Thank you so
And
much.
Okay, I have few questions, Hoda.
and most of your pins are like, I think something like 4.5 mm pin, chance school.
Right, sir. Because these were used in a government setup, I had only 4.5.
Yeah, and the
Otherwise,
problem is
my outside cases, I would use.
that stress.
Right, sir.
If you use the 6.6, the conical
Yes,
pin,
sir.
6
Yes, sir.
mm, it can take all the stress.
Right, sir. Right,
Less
sir.
number of pins. Now you are
Yes, sir.
compensating by putting more number of pins.
Right, sir. So the only thing was the availability of pins at my institute then. But for my outside cases, I use 6.5 mm pins only, sir.
And when you do a
Yes,
proximal
as you can see, she has
corticotomy,
used more number of pins, though she has
more
used
number of pins.
Yeah, she has
That is
Because
used
more
I
number.
wanted-
so that has given enough stability.
Yeah. And when you do a proximal femur corticotomy and transport, always try to put a pin into the neck.
Yes, sir. Okay, sir.
Virus.
Right, sir.
Ashok, I
in fact,
interrupt
if you do that
Ashok,
one,
I'm not able to hear.
that's very easy. You can you even before
Ashok,
doing
I'm not able to hear that.
you can put a K-wire into the neck under Shyam control, both AP and lateral. When you keep the hip in flexion, you get the lateral view.
Okay, sir. Right, sir.
If you keep straight, you get the AP view.
Okay, sir.
That is done. A cannulated 4.8 mm drill bit and the shank screw. Put the shank screw first
Okay, sir.
into the neck. Then forget about it.
Right, sir.
It can be attached anytime later.
Okay, sir. Right, sir. We'll keep
That's in a
that.
proximal femur corticotomy.
Okay, sir.
Otherwise, excellent cases. I think nobody will be, courage enough to face those cases.
Thank you, sir. Thank you, sir.
Very, very bad cases, and you dealt with in a very good way. I just also want to make a suggestion that instead of spacer, I saw in both your cases you use spacer and then you did bone transport. So instead of that, why not go for acute docking? Acute cooperation there.
Right.
So that shortens the treatment duration also.
Right,
And spacer, as Dr. Vasu sir has pointed out, is not really
not very useful.
Helpful. Actually,
Yes,
muscle is is not very useful when there is infection. On the contrary.
Right, ma'am.
Yeah.
Ma'am, the
I
gap
have,
was ma'am. The
sorry.
gap was very big for me to acutely dock.
Yeah, you can't dock it completely,
Yeah.
but semi-acute docking you can start. Yes.
Right, ma'am.
The compression at the
Right,
side.
ma'am. I'll keep that in mind.
I have also one question regarding the forearm thing. So, didn't you consider any time shortening of ulna instead of
Yeah, ma'am. I did shorten the ulna a lot. I did shorten, ma'am. After shortening, I had only about 5 to 6 centimeters to transport. So I thought, why not just give her a proper length also? But yes, I do agree. I could have shortened it completely and gotten away instead of transport. But yeah, yes, ma'am. I do agree.
And what about the position of wrist? In what position did you fuse?
Actually, it should have been a little more in dorsiflexion. But then, yeah, I didn't get that much intraoperatively. So yeah, ma'am,
it's a good idea to give at least 10 to 15
a little bit. It was only
so
about
that
7, 8, I guess. Yes, ma'am.
Okay, fine. Are there any more questions? Otherwise, we will move on to the next speaker.
I have one question. In cases of bone transport where you have docked the site, have you always taken the patient in for a surgery and docked it under vision and put bone graft in every case?
For long transports, yes, Madhura. I've taken them inside, removed the fibrous tissue, docked, and placed bone graft.
Okay.
For less than
Okay.
5 centimeters, no, I didn't. But for long transports,
Okay.
yes, I felt that was more safe than wait for the union to take much longer time.
Now, Goda, the reason
Okay.
was you put the bone cement there, and as Ruta mentioned, a subacute slow docking was not possible with the spacer there.
Right, sir. I do agree, sir.
Actually, make it closer. In about 2 to 3 weeks' time, as you said, now it will become just 6 centimeters. I mean, 5 centimeters.
Right, sir.
You can't do anything.
Right, right.
Okay, are there any other questions? Ishani, I should invite Madhura, isn't it? Yeah. So the next speaker is Dr. Madhura. Dr. Madhura has done MS Ortho from PGI SP Miraj. She is working here since 2018 as trauma and foot and ankle surgeon with immense interest in Elizaro. Her fields of interest are Elizaro and foot and ankle. She has 4 publications in national and international journals. She has been faculty for national and international Elizaro courses. And she's also interested in teaching and working on many projects of foot and ankle and rehabilitation along with Elizaro. So I request Dr. Madhura to go ahead with her presentation.
Thank you, Dr. Ruta, for this kind introduction, and thank you, Dr. Ishani, for this amazing opportunity. We've been all excited since the day you called us and invited us for this forum. I'll share my screen. Is my screen visible?
Yes.
Yeah. So I'll start with my cases. I've made a group of 5 cases which highlight different uses of Elizaro, which I've done till now. This is the first case where this man presented to me. He was a 50-year-old man and he was treated elsewhere with a compound injury to a distal tibia. He presented to me with this external fixator in situ, and the local site was already flapped elsewhere and it was completely clean. And all the blood tests for infection were normal. So after examining him, and the neurovascular status was also very nice. So my aim was to give him a united, fully well-functioning limb to avoid reinfection at the fracture site and maintain the alignment. So for him, I went ahead and did a bone transport Elizaro construct, where I did the corticotomy at the same sitting. Here, intraoperatively, I did not even touch the fracture site because it was completely clean and I did not want to do anything else for that. But because it was a very distal segment, I introduced a calcaneal 5/8 ring also, so that he can have good stability. So the entire surgery was done only in 2 to 3 sutures. The progress of the bone transport was very nice. Though, as Dr. Godha mentioned, while docking, I did not open the docking side, but let it just dock on its own. And once the docking was done, I converted the bone transport fixator assembly into a separate one by exchanging all the threaded rods and removing the calcaneal ring. And I also did a fibulectomy because I wanted to give accordion cycles distally. And 3 months later, this procedure was done. After 8 months, his fracture site was completely united. Even the regenerate was firm. And this is the recent follow-up. 3 to 4 months after the fixator removal, he is doing his functions well. He is a farmer with a local business. So he is walking in his farm, even on uneven surfaces. And he has a slight limb line discrepancy, but he's fine with that. There is slight stiffness of the ankle, I might add. So in my second case, she's a 23-year-old cricketer, and I must say that she is the most bravest patient I have ever seen. Rather, I would say she was a 23-year-old cricketer. Because of a ghastly motorbike accident, she literally could not even stand on her leg. And she had a compound injury to the ankle, the femur, as well as the knee joint. She was treated elsewhere many times for a femur nail Even Ilizaro was done for the ankle somewhere outside. And when she presented to me, she had no Ilizaro fixator, but had a very bad infection on the ankle and severe pain. So these were her pre-op X-rays, and the ankle is completely damaged. She could not even move the ankle joint, and the sinogram also suggested the same. So in this case, I was thinking about either joint salvage or joint fusion, but with infection eradication, of course. And I really did not want to ampute her because she was very young and she was very determined. She also had she also has a extensor lag. Her extensor apparatus is completely destroyed, so she cannot extend her knee. Given all these history and all the consideration, I counseled her well, and I went ahead with ankle fusion or tibio-talar fusion with an Ilizaro. And I put in stimulan with a colistin colistin antibiotic in it because of the prior culture reports she had with her. So here I had to excise distal half of the fibula almost, distal end of the tibia, and a 5 centimeter gap was created, out of which 4 centimeters I could dock, I could compress. But the remaining 1 centimeter, 1.5 centimeter was very difficult. So I left it for gradual compression. The bone compression continued till a good bone contact was achieved. And I added a proximal ring around 3 months later and did a corticotomy to achieve the length, which was short. And at the same time, I did some correction of the distal ring so as to align the tibia well. And she gained 6 centimeters thus. There was a good tibio-talar fusion. And she was on this fixator for almost 8 months for a solid union. And it united really well. Now I have to take care of her knee in the future. And she was walking, she was playing with the cast on. Sorry, the videos aren't playing, but she was very comfortable. Now, this is the third case in which a 24-year-old female presented to me with deformity in both her tibias. And it was progressive since the last 10 years, and she had not even walked or not even stood up for 10 years. So her bones were like really brittle, and this was the deformity in both her tibias. And it is an oblique plane deformity. This is how she used to bend her knee with very low power in both the quadriceps and the hamstrings, but the joints were supple. So for this case, we had two decisions to make, whether to perform both the surgeries together or to perform both the surgeries separately, and in what way. So for the first side, on the left side, we decided to go for an acute correction. And we had to almost excise 4 centimeter of the bone in the mid shaft, and we fixed it with an interlock nail and a plate because the bone was almost like butter. But the problem with this surgery was that she had severe pain and neuropraxia on the ipsilateral side. And we decided to just wait for some time till we did her second leg. So 4 months later, we planned for the right side. And here I thought I would go for a gradual correction and limited weight bearing. So I had two apparatus with me, like hinges and distractor, the usual one, or the depth fix fixator. And I was just out of the depth fix course, so I was very eager to do depth fix. So I decided upon a single level osteotomy, even though it is a O kind of deformity. So I went ahead and put on this Ilizaro apparatus with depth fix struts. And with the program, I calculated the time required, and within 23 days, the deformity was completely and very nicely corrected. Once the deformity was corrected, I replaced these struts with threaded rods. As the rings are not parallel to each other, I have to use conical washers, and I allowed her to bear weight at this time when the threaded rods were put in. And this was after fixator removal 8 months ago. And this is the final recent image, and she has a shortening on the right side of 3 centimeter. And we did protect both her tibias with a AFO because we didn't want the refractures to happen there. And these are her current walking videos. We had to work a lot on her physiotherapy. Her truncal weakness was very bad. She could not even stand up straight. Her hips were weakened. Her gluteus needed a lot of strengthening, quadriceps, hamstrings, everything. But now she's comfortably walking with a shoe race and she's happy. In this fourth case, I have a 40-year-old male who was injured in a road traffic accident, and he presented to us with a distal femur and a proximal tibia fracture, just a floating knee, we thought. And these were his immediate pictures, and it was quite a ghastly injury. The quadriceps tendon was also injured. So our initial plan was to put in an X-fix, debride the entire thing, put in beads, suture the wounds, and then fix both the distal femur and the proximal tibia with internal implants. But little did we know that on the 7th day, when the proximal tibia swelling had gone low, we opened the wound and there was still a lot of discharge. So we went ahead with fixing the distal femur condyles with lag screws, and I did a Elizaro fixator for the proximal tibia. Here I've used the olive wire as a reduction tool to get proper alignment and reduction. And I removed this olive wire, which was placed on a plate as a drop fixation after 6 weeks, so that I can start with the accordion maneuvers. 7 months after the Elizaro application was done, the fracture seemed united, so I dynamized the fracture and he was allowed to bear weight on it. The posterior, the middle, the medial and the lateral cortices are very well united, but the anterior cortex, there was a bone gap. So a slight gap was still seen there. And after dynamization, there was no pain. This video is taken just before the removal of the Elizaro frame. And we safely removed the Elizaro. And this is his current X-ray. And he's very happy because his knee is still stiff, but it was stiff from the beginning. The quadricep tendon was torn, and he will need a quadriceplasty in the future. So this is the last case, which is very interesting. So I thought of sharing this. A 50-year-old female presented to me with a lot of swelling in her right tibia and her foot. And it was very foul smelling. And she had history of gradual increase in the swelling and features of cellulitis almost going into septicemia. And she presented to me 1 month after the symptoms had started. She was advised amputation at 2-3 centers. But just for the last opinion, she came to me. And we did the Doppler to see the venous and the arterial structure, and it was okay. The blood tests were highly deranged though. So my plan was to first amputate her limb so that she'll be free of the disease. But while debriding, we thought we can give a chance to salvaging the joint, salvaging the limb. So I debrided it, put in stimulan with an Elizaro fixator. As you can see in the CT, the midfoot joints are all involved. The ankle joint was not so involved, and the distal tibia had a small lytic lesion. So after debridement and putting stimulan with vancomycin, I took 2 samples for culture. First was from the wound, and second sample I took was from the distal tibia after cleaning and repainting the entire limb. And the sample from, so this is the post-op image with stimulan and a 4-foot ring, a calcaneal ring, and a distal tibia ring. The funny thing was the sample from the foot was completely contaminated with polymicrobial infection, but the distal tibia biopsy came positive to be for tuberculosis. So we started her with anti-TB treatment for complete of 9 months. And throughout the treatment, she was walking on the Elizaro fixator with a chappal. And she did require 2 small flaps near the ankle joint where you can see the wound, but they resolved after the fixator also and after dressing and the plastic surgeon did a good job here. So after around 6 months, I removed the fixator and she was walking in an AFO. And now it's been 1 year since her treatment. She's very happy. The ankle is stiff, but she has no complaints. The midfoot joints have a fibrous union, and she drops by every 4 months just for a follow up and greet us. So, with these presentations, I would like to thank everyone, and I thank my patients most importantly for their faith. And I thank Dr. Ruta, Dr. GSK for this opportunity, and also my residents, Dr. Rund and Dr. Abhijit, who helped me with all these slide shows. Thank you.
Okay. Thank you, Madhura. So we will take just 1 or 2 questions, not more, because we are behind time. Yes, Dr.
Yes,
Ravi.
sir.
Sorry, first up, sorry. Who is speaking?
Madhura, these were
Dr.
nice
Ravi.
cases actually. Both of you have presented well. Actually, it was really nice cases. Initially, Goda and you also. But there are 3 or 4 questions mine, but I will take one as ma'am said. So regarding your first case, was it infection in the initial episode when the patient presented to you?
No, sir.
No. So then, was there any specific reason why have you not opted for internal fixation as compared to the Lizarov at that time?
Sir, because I was scared of the reinfection rate, and there was a flap done already. So it was a compound wound, and it was just 1.5 months prior when all these surgeries had taken place. And he had a good fixator on, the Shanspin were good. So if I had to do an internal fixation, I would have to give him a X-fix break. And then again, the alignment would have been lost. There might have been reinfection during that time because of instability. So I just went ahead and converted that entire setup into an Elizaro bone transport fixator.
Plus, there was shortening, isn't it?
Yeah, there was a gap. So
was a
I
gap.
would have required either shortening or put a lot of bone graft in it and an internal plate. But again, the chances of infection, I was really scared of that. And it was very near the joint. So I didn't want to infect the joint.
Outcome
And
was
the
good.
local set was very nice.
Outcome was good.
Outcome was good, sir.
And regarding that stimulant, how much
Yes,
you were
sir.
convinced with using stimulant in your second case and especially in the tuberculosis case?
Sir, I used the stimulant for the tuberculosis case because of the polymicrobial infection. Other than that, I had no other reason. But for the ankle fusion that I did for the girl, actually there was no major role of stimulant in that case.
Yeah, because it's a
But it
local
was,
disease system, and once you are done with the good kind of a
yes,
development, it's my opinion basically.
yes, sir, yes,
Outside
sir.
from-
1 or 2 cases I had used stimulant earlier too, but nowadays if there is Elizaro, I just don't use any other biological material because everything is done by the fixator.
Nice. Thank you.
Thank you, sir.
So, are there any questions? Otherwise, I will go to the next speaker.
Mama, Wi-Fi.
So, I'm really happy to introduce this dynamic young lady, Dr. Ishani Chaudhary. She did her MBBS from the prestigious KEM Medical College in Mumbai, her D-Ortho from Sancheti Institute. And right now she's working as senior resident in Government Medical College, Akola. She has done fellowships in limb lengthening and deformity correction from Center for Elizaro Techniques in Akola, of course, and Palais Institute, USA. She has also done a fellowship in knee preservation surgery from Japan. She has 2 publications and she has written 2 book chapters as well. And she got Best Paper and Poster Award in POSAC 2019, Best Paper MOACon 2019, and PK Mullah Firoz Award IOACon 2020, and Masala Wala Best Paper runner-up in 2022. So here is Dr. Ishani Chaudhary. Please go ahead with your presentation.
First of all, thank you so much for that kind introduction. Really appreciate your kind words. Can you see my screen, everyone?
Yeah, yes.
Yes. Okay, great. Thank you very much, ma'am. And I would like to welcome everyone. Thank you to the speakers before me. You both, Dr. Goda ma'am and Dr. Madhura ma'am, have presented great cases before. I would like to thank all our panelists who've joined and are asking great questions which have led to great discussions. I would like to welcome and thank Dr. Ashok Shyam and OrthoTV for this platform and ASAMI India for this opportunity. So today I will be talking about, unfortunately, I don't have a variety of cases. It's just the same type of cases. So we'll be focusing on achondroplasia. And I'll be talking about the latest case series of extensive lengthenings done at Center for Ilizaro Techniques. All right. So here is a boy, 5-year-old. He presented with complaints of this typical features and short stature, and he was so he had bow leg deformity and could not sit cross-legged, had that typical features of trifid hands and inability to extend his elbows, and the facial features of a broad forehead, then mid-face hypoplasia. And so went ahead and took his full length X-ray and found that these were his tibial and femoral measurements with a typical look of the chevron shaped metaphyses, overlong fibulae, and a varus deformity in the tibia and coxa breva. Now, obviously, the diagnosis is achondroplasia, which is the most common form of short limb dwarfism, one in about 25 to 30,000 births, with normal trunk but rhizomelic dwarfism in the appendages, with an upper to lower segment ratio of 1:0.6. I'm just quickly introducing this because this is classified as a rare disease. So we know a little bit about the background of it. It's caused by a mutation in the FGFR3 gene, which causes a change in the way the uh, chondrocytes mature and in the physis, leading to short stature. Along with that, there are other spinal features which come along. Now, when the patient came to me, there's a question of what can we do about this problem. So one option is, as a limb lengthening surgeon or as an orthopedic surgeon, or most people would actually go about thinking that this is not a solvable problem or there are no treatment options for it, which would leave such an individual as an abnormally short individual with an average height that they can attain being 125 to 135 depending on centimeters, depending upon whether they're a female or a male, and with difficulties in so many psychological and social factors. The other points which are discussed quite a bit, which are the non-operative or the pharmacological options, which of which the recombinant growth hormone has been around for a while, and the new kid on the block is vosoritide, which both consist of daily injections, and the unsatisfactory part is they only lead to about 2 to 3.5 centimeters of height gain. And there are some other compounds that they have which are in trial. So that's not an option currently. But what has been in the treatment protocol for a long time is basically limb lengthening, and which is also known as extensive lengthening to help restore the body proportions for better social psychological integration. So when this 5-year-old boy came, it did a full length X-ray for him, measured his segments, so the femur as well as the tibia. This is what we started off with. So operated with a fibulectomy for him, applied the Ilizaro ring fixator. It was a 2-ring construct with rings parallel, the upper ring parallel to the knee joint and the lower ring parallel to the ankle joint. It was connected with 4 struts and hinges. The corticotomy was done percutaneously. It was a unifocal corticotomy done with multiple drill holes and later on completed with an osteotome at the metadiaphyseal junction. So now after this was done and the entire fixator was applied, the patient goes back to the room for the next 5 days and follow up. After that latency period, we started lengthening at the rate of 1/4 turns 4 times a day to start off with a rate of 1 mm per day. Now, regular follow-up was done in terms of checking for how much growth is happening As you can see, I've mentioned the dates so that we know how much was going on. And the image on the left was right after the surgery. Before we started when we started the lengthening on the first day, then within 8 days, that is how we gained 1 centimeter. So continuing the rate of 1 mm per day. He was called back initially once every 2 weeks, and eventually it went on to going once in a month. So, till the time that the lengthening was going on, monitored his length, the quality of the regenerate, how is he walking, how is his gait, how is his pain, and is there any sort of a deformity. So, at around 4 months from the time of the surgery, the lengthening, the distraction was stopped, and after that, he was allowed to keep walking and checked once a month to see how is his consolidation happening. So these are the X-rays with routine follow-up. And we found that within 2.5 months from the time we had stopped the lengthening, after that, he was all ready and done. So I removed the fixator at 6.5 months from the time the surgery was done. And here you can see this is measuring the tibia measurements are there. So it started off with a 146 millimeters going on to 105. Just to put it in clearer numbers, it was 6 centimeters of length, which I gained in 6.5 months. So that, if you calculate, is 40.4% of length with a healing index of 1 month per centimeter. And thankfully, fortunately, there were no complications in this patient. He was monitored at every follow-up. The initial rate of follow-up was once in 2 weeks till the lengthening got done. And after that, once a month during the consolidation phase. And here he is. Initially, these are the before pre-operative pictures, and this is what he has sent me a couple of days ago. The knee deformity is better, and I hope this video plays. This is him walking. He's a very chirpy child, he's a very friendly child, and it was quite a joy to see him come for follow-up and treat him. You can see he's always goofing around a little bit. And these were his results. All right. So now he is from the time that from the time that I removed the fixator and got this, he is about 6 months from the time into which we can go in the next stage for him, which is the bilateral femur lengthening. And the final thing that I have in plan for him is the bilateral humerus lengthening. And a question that comes in cases of achondroplasia is when to lengthen. So for this child, I started at 5 years of age. And this is something that has helped him. He's very young. So he can go back to his school and, he doesn't get teased around much with his peers. So far, all the cases that I have, which I'll be showing, are also the cases who have come around 4 years of age, 6 years of age. There's another girl who's come at 9 years of age. One of the things that going through the literature, one of the things that I have followed and also followed Dr. Millen's principle is not to start the lengthening in these cases with any sort of a planned number in mind. But the most important thing is regular follow-ups and to keep a very close watch on all of these patients and just go for whatever is the safest maximum possible. This is the one thing that I have been trying to do. This is another case. This is that 9-year-old girl who is currently under treatment. These are her X-rays. These are taken right after the surgery and then about 1 month from the surgery. And this is her latest follow-up. So these are the X-ray on the latest follow-up. So right now, at this point of time, this is the clinical picture that she has sent right now. She came on the 27th of last month. I've stopped the lengthening for her. And that's 3 months from the time that I started. And now she's in the consolidation phase since the last 1 month. All right. Now, there are some of the children that I'll be showing. Fortunately, the ones that I have done, there has been no need for a foot frame so far. But in case there is any at all. That will be depending upon the ankle range of motion, and anytime after the initial distraction, anytime from the first month on, if it is needed. If I need in any of the further patients or these cases which are in treatment, this is one more boy who's around 5 years of age. If in case it is needed, I might have to go for it. Another girl who has finished bilateral tibial lengthening. And this is the youngest that I have treated, a 4-year-old boy. He's currently in the ward. He's 9 days from the day of surgery and 5 days since we started the lengthening protocol for him. So I thank you for your kind attention. If there are any questions, I'd be happy to answer.
Very good cases, Ishani. Very good work.
Thank you, ma'am.
Can you stop sharing your screen, please?
Yes.
Can you hear me?
Yes, sir.
Am I allowed to add, Dr. Ruta?
Yes, of course, sir. Please go.
Actually, I'll just share my experience. She had done excellent work, excellent cases. But actually, during my fellowship days, I was taught by Dr. Vrisha Madhuri. I was a fellow with her. I especially went to, so what she taught me, that the frame should be 3-ring frame. And she used to do 2 corticotomies, one at the proximal part and one at the distal part. And fibular osteotomy was done and distraction was done at both the sides, but not 1 millimeter per day, 0.5 to 0.75 millimeters at each sides. The benefit is that, in an achondroplasia, when you do 2 corticotomies, you can gain more length and the consolidation is better. That's what she taught me, and I've been doing that. I've never faced a problem, and Ishani did it with 1 corticotomy. I do with double corticotomy, and it works. Now in achondroplasia, Ishani, you should try to do the second lengthening after gap of 4 years. The rule of 4. So
Okay,
probably what happens is that if you use only 2 rings, you have been using 2 rings only.
2 rings, yes.
Probably you try now this thing, use 3 rings. Okay.
Okay, sir. Sure.
So what happens? One is see, your father is a master, but what I've been taught during my fellowship days, I'm sharing my experience. See what happens when you use 3 layer rings, the stability is better. Okay.
Okay.
You are doing 2 corticotomies. Okay. But the rate is less. Okay.
Right.
Consolidation, if you do this way, you will find that beautiful consolidation happens and early consolidation happens.
Okay, sir.
Fixator time reduces.
Okay.
So try this thing and see how it works for you. But she was very adamant, and I've been following this from last more than 20 years, and it worked out very well. So एक बार एक patient को ऐसे करके देखना, and then you see the difference. You can even get a publication of 1 corticotomy or 2 corticotomies and compare that which patient has a better regenerate, or what is the consolidation time difference between 2, what is the lengthening index. So you can do this thing, because if you are having so many patients, so I think you should do a comparative study. And what are the comments of Dr. Ruta, because she also has a good series of...
Dr. Chaudhary, I think, is the master in this field, but I feel the literature now says that single corticotomy in achondroplasia is better than double level lengthening. The complication rates are way less with single corticotomy. The time period and the lengthening achieved, there is not much of a difference actually. So
no,
nowadays,
actually,
to go for single corticotomy as Ishani has done.
No, what I was telling Ishani that let her compare, do a study, so that it will be helpful for all of us. Because my way of doing is...
I have done 2 osteotomies, and I have nowadays sticking to just single corticotomy. And if you scan the literature, the literature supports single level osteotomy in achondroplasia now.
No, but what made you shift? Was it not working?
The problems like complication, all possible complications of limb lengthening, including equinus deformities, knee problems, knee subluxations, and everything. And if you compare time period, you have to go slower with double level corticotomy, whereas you can go even faster, 1.5 millimeter at the rate of 1.5 millimeter also with single corticotomy. Complications are way less. So you are not saving time with double corticotomy, and complications are less. So I feel going for just single corticotomy is a better plan.
Yeah, very, very nice presentation, Ishani. Congratulations. And
Thank you, sir.
I would like to totally agree with Ruta. The more number of corticotomy, more headaches.
True.
And more number of pins and tiny children. More
Yes.
pins and more complicated corrections. It's actually not worth.
Yes, absolutely.
No, there is no trouble when you do in a single. May make your life easier, as well as your patient's life easier. Cleaning and dressing is much more easier.
Yeah.
And your complication rate naturally comes. More number of osteotomy, more complications. More pain,
Yes.
more costly. More costly. So I think it is not really worth.
Yeah. One question about injection vorititin. Did I pronounce it correctly? So is it available in India? And if it is available, how it should be administered? When?
Ma'am, so injection vosoritide, I am not aware
Vosoritide.
I'm not aware if it is available in India, but I will definitely try to find out if what is the cost. But it's definitely a daily injection that needs to be taken for over a year. So I think that would be more cumbersome, and really, I think the cost, the daily effort, and the final result of it, which is just maximum 2 to 3 centimeters gain, would not be a beneficial return on investment for the patient.
Here most of the long bone is affected, not the other cancellous bones. I think it is more of a local, a long bone disease than a systemic one. It's very, very doubtful whether a systemic growth hormone or similar will work for here, unless you have a gene therapy.
And actually, the growth hormone is also very expensive. One injection of nodotropin, it comes by the trade name of nodotropin. And it is, almost one injection is 18,000, which you can just have it for 7-8 days. The cost is also very prohibitive in using growth hormone also. So probably I feel that better is our Elizarov, at least it is cheaper for the
Definitely.
because my younger son had a growth hormone, younger one, and I know that how much money I could afford it, but other people cannot afford it.
Are there any questions? Yes, Ravi.
Ishani, nice cases. Just
Thank you.
have one query, one or two. One is regarding the growth inhibition in these children, especially the young lads, with respect to the amount of lengthenings that you do, and when it comes to the tibia especially. So what's your experience with so much of cases and all those things?
So we haven't seen any growth inhibition.
Because
In fact,
literature talks about that thing.
it does mention about it, but from the experience of having done these cases, so we haven't encountered these growth inhibitions. In fact, it has actually promoted the growth. Because there is also a study which talks about children which have undergone lengthening versus children which haven't undergone lengthening, and they have found that their growth potential has been much better.
Okay. Because you have shown number of cases, that's why I asked this question basically. And so how much length you want to achieve in tibia and the femurs when you do the lengthenings of these children?
Thank you for this question, sir. So I don't start off with a premeditated number or a pre-planned number. It is all follow-up to follow-up, and how the patient is tolerating, how is her or his range of
Definitely,
motion.
there are a lot of confounding factors are there.
Yes.
But at
Yes.
what limit you want to go ahead with?
So, I mean, um, there is a series that Sir has done, which is much larger than mine. But what I have been handling for the last 2 years, I've only gone up to 6 centimeters.
In tibia
So
or in
in
femur
tibia,
or as
in
a whole?
tibia. No, in the tibia, in the first stage, 6 centimeters.
Okay.
Yes.
Thank you.
Yes. Thank you.
Most of the time, the lengthening is prevented by soft tissue, not by bone.
Yeah, exactly. Because in these children,
When
when
you
we have the
develop
congenitals, when we are dealing these congenital
knee
issues.
or an equinus, naturally we have to stop.
Yeah, exactly.
Yes. Yes.
And you continue your physio for that.
Yes, sir.
Yeah, I give promise only for 5 centimeters, and whatever I am getting extra is a discount.
Yeah, exactly.
And I ask them, I just tell them, do more of exercises, more stretching, you'll get more length. 5 centimeters is the only guarantee. The rest of it they can make.
So,
Yeah, I
Ishani, your youngest patient was just 4 years old, is it?
Yes, ma'am. Yes. He's currently in the ward.
That's
I was about to ask that at what age you
young.
want to start it, because you have started at 4.
So the Milind sir has done a case as early as 3. But I think I am more comfortable at starting around the age of, I would say, a little scary, but would definitely be very comfortable around 5 years of age.
And regarding to the 4 segment and versus 2 segment lengthenings and all those issues?
Sir, 4 segment lengthening, the concept is because the internal devices are available outside.
Yeah,
I would
that's
only be
pretty
comfortable with a bilateral tibial lengthening, then take a good gap of about a year. Sir mentioned 4 years, but after a gap only, then bilateral femur. That
Okay.
only two at a time.
Okay.
Yes, sir.
That's
4
really-
years he mentioned for re-lengthening of tibia again.
Right. Okay. Okay.
Not between the
Yes,
tibia and
yes, yes.
The rule is
Yes.
now what
Thank
I am
you.
following is 5, 10, 15, 5 years, flexible little bit. And when you do a surgery before 5 years of age, 5 years of age, mostly the children, they forget about it.
Yes,
They
yes,
remember the
yes.
trauma of surgery.
Definitely.
After 5 years, they keep remembering it. So your
Yes,
next surgery becomes easy when you do at the age of 4.
definitely.
By,
Thank you, everyone,
by
for
late
I
10
think we
years
will
and
go
all,
to the next presentation.
because when you do at a young age, the children always think that it is unnecessary, they are out torturing me. But at the age of 10 years, they know I am shorter, I want it to be height, now they will be receptive for the treatment. Before that, they will be always angry. They will fight with the mother. Why are you treating me? I don't have any problems.
Right.
Yes. As soon as they become 6 or 7, they are extremely motivated to
Yeah.
become taller.
Yeah.
Yes. Yes.
Okay, last but not the least, gives me great pleasure to introduce Dr. Aradhana Rathod. She did her MBBS from Kalburgi. Okay, and her MS from Bangalore Medical College. She has done fellowships in limb leathening and deformity correction and foot and ankle. Right now, she is doing a fellowship in USA in foot and ankle. She is assistant professor in Bangalore Medical College, and her special interests are, of course, foot and ankle and Elizaro. She has been faculty in many national and state conferences and Elizaro workshops. She also has organized many foot and ankle and Elizaro workshops herself, very successfully. So I request Dr. Aradhana to start with her presentation.
Thank you so much, ma'am. Thank you for the wonderful introduction. Thank you, Ishani, for conducting such a wonderful webinar. I will share my screen and thank you all the panelists for joining and giving good inputs for our cases. I hope my screen is visible.
Yes, ma'am.
Yes, go ahead.
Today, I will be presenting 3 cases which were challenging case of infection and deformity, which I have managed by ring fixator. So the case 1, it is not that bad as Dr. Godhasiri presented. But this case came to me. 45-year-old female. She was cook by occupation prior to the injury. She had past history of road traffic accident where her forearm got injured, and it was open injury 6 years back, and for which external fixator was applied and flap was done. After that, she has not undergone any surgeries, but she had in fact come to me for disability assessment and disability certificate, where I told that probably some treatment can be given for her, at least for her forearm stability. So here there was a tiny sinus had on and off discharging sinus from here. She used to use a local made brace for stability of her forearm. If I have to say, elbow movements were normal, wrist movements were restricted, and finger movements were restricted other than opposition between index finger and thumb. Other metacarpophalangeal joints movements were restricted. So intraoperatively, I can go back to the X-ray. Here we can see the ulna bone loss is much more as compared to the radius, and we can see some cross union which is occurring here, but not very well seen in the lateral view. In ulna, the ulna was tapered and sclerosed, which I had to resect. There was a gap mismatch definitely. The ulna, the radius resection was more, and some of the radius which I resected, I soaked it in vancomycin, and later on used it just to pack around the docking site. And there was a cross union at the interosseous membrane, which was interosseous membrane was released to release the cross union, and ring fixator was applied. This was a 2-ring construct. Because of docking, the forearm was shortened, and initially I had to fix the ulna and then radius, and this was how the frame looked like. And this 1 mm gap was reduced later on by compression. There was some amount of angulation, but still I accepted it. Then over 10 weeks post-op, we can see the union occurring beautifully in radius as well as ulna. And she was so happy to go back to her cooking. We can see some finger movements which are happening nicely here. And she is doing all her day-to-day activities even with the frame on. No discharging sinus till now. And at 8 months, I removed the frame after confirming the union, and this was how the forearm looked like. There is some dorsal angulation, but still I accepted it. And this is her pre-op and post-operative pictures. This was during the disability assessment when she came to me, and this was during the follow-up after the cast removal. She is really doing well, and she is very happy with the surgery. Let me go to the second case. The second case is 37-year-old male patient who presented with pain and swelling in the right leg since 20 years, wound and discharge on and off since 20 years, unable to bear weight in the right lower limb since past 1 year. He says vaguely he remembers there was a trauma to the leg which was treated conservatively in childhood, and history of surgical treatment for the same complaints 1.5 years back. He was a known diabetic since 2 years on treatment, non-alcoholic and non-smoker, but he was on antidepressants because of on and off discharging sinus. If we see on examination, definitely this the patient has anterolateral bowing. There was on and off discharging sinus where I have marked, and these were the previous surgical scars where intervention was done for the same patient somewhere else. And there was thickening of whole length of the tibia, and if we can see the x-rays and CT scan here, the whole of the diaphysis doesn't have any corticomedullary differentiation. There is bowing of the tibia. and the other pictures represent his previous surgical intervention where saucerization, curettage and beads placement were done. If we see the ankle movements, plantar flexion was normal, dorsiflexion was 10 degrees, definitely due to the deformity. Now, this was the X-ray when he presented to me, and in fact, the patient was told that if the infection is not getting controlled, he can undergo amputation. In few places, he was advised amputation. So I thought of giving another try of extended curettage and saucerization. I convinced him for that. Then intraoperative finding, if we can see, I had to make a very big window. In fact, the complete anteromedial cortex I have to remove to enter the medullary canal, the so-called medullary canal, and I had to remove the inner third of the cortex as well as the medullary canal which was present in this case, and fill it. The red represents vancomycin loaded spacer to obliterate the dead space now, and I waited for 2 months. So second stage was done after 2 months. The plan was removal of the spacer and fibular transport in this patient. But intraoperatively, I saw that flipping of anterolateral cortex over the posterior cortex, the thickness of both together was quite good enough for me to leave both the cortices as it is and wait for the hypertrophy. This is what I thought intraoperative. So I did the same and put lot 4 olive wires anterior to posterior and compressed it and connected it with a plate, long plate. This was a 2-ring construct with additional Shan's pins I used to give stability, and I made the patient walk the next day itself. Here we can see there is anterior to posterior compression in the lateral view, and this is at 9 months. During 9 months, I could see a very good consolidation and union at the metadiaphysis junction. So I plan to remove the frame, and this is post removal of the frame. And this is at 13 month. We can see layer of cortices being adding up, and I thought intraoperatively in this patient. So this is during his and I have supported the patient after frame removal with a cast. Now after 1.5 years, I have bivalved the cast, but still the patient um, uh, is on a bivalved cast now so that he can take bath. This he has sent me on a WhatsApp video. Here we cannot make out which side was operated. He does stage decoration and he's back to work. So last case is a translational osteotomy. This is the most challenging case which I ever had. This patient was 24-year-old male patient with open heel injury where debridement was done and calcaneus was completely removed. What we can see here from the posterior aspect is the inferior surface of the talus and the ankle, and we cannot see any sole over the heel. The sole ends at the midfoot. There was no dorsalis pedis pulsation felt or no posterior tibial artery pulsation felt. The foot was entirely living on collaterals. Sensation of great toe and second toe was present, but the sensation on other toes were absent. So this patient requested for a salvage of the foot, which was very difficult for him to convince that any intervention can in fact cause gangrene of the foot, but patient was still bent upon that he wants to have the foot of his own and not any artificial limb. So this is how he used to hop. In fact, he came hopping to the OPD, and next was my planning. This was my planning. Initially, I thought of a dorsal closing wedge, but I couldn't get the sole over the posterior aspect only with the dorsal closing wedge. So I planned a translation as well in this case. The translation I could easily achieve with a ring fixator. So this was intraoperative. These are my K-wires for my osteotomy, dorsal closing wedge. Because of osteoporosis, I could just get away with the thin osteotome, and this was how the dorsal closing wedge easily I could achieve. Um, this was done in staged because initially I did a osteotomy and waited, because if any gangrene has to occur, it has to occur during that time. And later on, after a week, I planned for frame fixation. So this is around 2.6 centimeter of dorsal closing wedge, which has happened in this case. And the translation, this is the sole of the midfoot, which I am planning to translate posteriorly, like seen in the picture. And this was the ring. Here I would like to take some time to explain the rings. This was a total 6 ring construct, 3 for tibia and 3 for foot. The fourth and fifth ring, which can be seen here in the clinical picture, the fourth ring has been put in the Siam image. The fourth and fifth ring have to be parallel to each other for the translation to occur. And this is how the translation has to occur. The dark brown represents the inferior aspect of the talus, and the foot sole represents that it is anterior and medial. The translation has to occur posterior and lateral. So I have used 4 struts here, 1, 2, 3, 4, which I have labeled, and the orange represents the direction of the translation which is supposed to occur. On the right hand side, the 3 ring construct on the tibia will give me a lengthening in the proximal corticotomy site to match for the calcaneus loss. So over a period of time, we can see here the 5th ring is much anterior to the 4th ring here. Over a period of time, here we can see when he has already translated, the 5th ring is posterior to the 4th ring now. So the translation has occurred completely, but the dorsiflexion I was unhappy. So I did it acutely after the correction and planned to maintain it plantigrade to the tibia and fixed it in that position. And this is after the fixation and follow up. Here we can see the sole beautifully gone posterior, and there is consolidation at the osteotomy site occurring. This patient was seen last before he went to his native. I am just waiting for frame removal in a month or so. So this was his final picture before I sent him back to his home. It is a short foot though, but he is very happy that his foot was salvaged. There is no necrosis, none of the toes were lost in this case, and the length of the limb has been achieved. The main aim of presentation of this case is these are the wonders which we can do with only ring fixator application. And thank you so much.
So thank you, Aradhana. The only word that I can say is wow, what fantastic cases. The last case was really good. The construct that you used was really nice. And I think because you're an expert foot and ankle surgeon and a deformity correction surgeon, you could, figure out how to correct that deformity. Very well done.
Thank you, ma'am. Thank you, ma'am.
Are there any questions?
Aradhana, it was fantastic.
Thank you, sir.
Good.
Thank you, sir.
Really
Thank you, sir.
You've done a lot of homework.
Yes, sir. Yes, sir.
real fantastic, and I think no question.
Thank you, sir. I'm just waiting for the final follow-up to come so that I can represent this case in the coming ASAMI. It is a nice case to present.
You should also publish it because it's very
Yes, ma'am.
unique. The osteotomy and the planning is really admirable. I really congratulate you for very good planning and execution. Great work.
Thank you, ma'am. Thank you.
Okay, so we come to the end. I hope there are no other questions for Aradhana. Okay, so we come to an end. Thank you very much for fantastic presentations. And the discussion also was very engaging and insightful. So, ladies, your work is truly an inspiration to all the aspiring Elizabeth surgeons. Thank you very much for your presentations and thank you very much for joining. And I ask Ishani to give concluding remarks and then we'll end this webinar.
I think it will motivate more ladies to take up Elizabeth. And it's going on Ortho TV. Many people will, the orthopedic surgeons will see. So it will really give motivation to join and take up Elizabeth as a specialty.
Very true.
So thank you so much, everyone. Absolutely. The idea of this actually came from the most recent ASAMI Con 2024, where we had so many women at ASAMI Con in ASAMI, and it was thanks to the enthusiastic support of our moderator, Dr. Ruta ma'am, who has been kind enough to support us and encourage us. And it has, Dr. Rajat Agrawal has been very kind enough to give a go ahead for this She Unites program. Thank you so much, Dr. Manish Dhawan sir, for joining us right after flying in from Russia. I really thank Dr. Ravi Chauhan sir for being here and asking great questions and offering a better discussion. Thank you, all our speakers, Dr. Godhasiri ma'am, Dr. Madhura ma'am, you presented fantastic cases, and Dr. Aradhana ma'am, who's just absolutely everyone was appreciative of the mind-blowing work that you're doing. And thank you for joining us from America. Thank you, Dr. Vasudevan sir, for being here with us. I would like to thank OrthoTV, Dr. Ashok Shyam sir, for this platform. And this is just the beginning. We hope to come back, to unite back, and see all of you again for She Unites for the next episode. So see you soon, and here we conclude the meeting. Thank you.
Yeah.
Thank you. And good night.
Thank you, ma'am. Thank you, sir.
Thank you.